Good evening, everyone.
Hello. Hello.
All right, I am going to get things started. Thank you guys for joining us for our COVID-19 webinar. I am Dr. LaTanya Washington. I'm the president of the Bluff City Medical Society. We are elated that you have joined us this evening. I will go ahead and get started and let you guys know what all we have in store for you this evening. So as far as housekeeping, we are streaming this live on the Bluff City Medical Society Facebook page. A recording will be available on the YouTube page. We were unable to do a live stream from our YouTube page, so we apologize for that. Please take a moment to like, share, and start a watch party or share our video this evening. We will make our recording available on the YouTube page after this event, and you can also watch it on our chapter website. And then please enter any questions that you may have into the chat feature. If you're joining us on Zoom, you can enter it into the Zoom chat, or you can enter it into the Facebook live chat, and we will make every effort to get to most questions, or as many as we can in our time constraint here. So I'm going to start off with giving you all a brief introduction to the Bluff City Medical Society. I know unless you're here in the Memphis area, you may not be familiar with Bluff City Medical Society. So our organization was founded by Dr. Miles Link, who is also a founder of our national organization, the National Medical Association. The Bluff City Medical Society was founded in the early 1900s, and as you can see, we are still in existence today. We are an organization for physicians of color, and we are leading the way in the community. We have over 250 members at the current time, and we are open. We do a lot of service projects within the community, and most of us who are on this panel and also in the community, we are accepting new patients. So feel free to join us as well. So the purpose of this COVID-19 webinar is to answer your questions about COVID-19. I know that you all are hearing a lot of information online about COVID. We want to make sure that we are a resource for you of accurate information. So for our panelists, I'm going to introduce everyone here. There's much experience on this panel, and I'm excited that all of these fine physicians have joined me this evening. So I am Dr. LaTanya Washington. I am the president of the Bluff City Medical Society. I will serve as moderator for the evening. My specialty is internal medicine and pediatrics. I went to undergraduate at Tuskegee College, did my medical school at University of Tennessee Health Science Center, completed internal medicine and pediatric residency program at University of Arkansas for medical sciences. And then I have an MBA from Auburn University. I currently work as the physician advisor at St. Francis Hospital, Memphis. So starting with our first panelist, Dr. Keto Lord. Dr. Lord is an emergency medicine physician. He serves as the medical director at Regional One Hospital and is assistant professor at University of Tennessee Health Science Center. He received his undergraduate degree at Morehouse College and his medical training at Howard University. He completed his residency at Yale University, where he also obtained an MBA. So Dr. Lord's practice is at Regional One in the emergency department. Next, we have Dr. Adesa Jones. Dr. Jones is a Memphis, Tennessee native. He attended Tuskegee College for undergraduate and then Brown University for medical school. He completed his internal medicine residency at University of Tennessee Health Science Center and then completed a critical care fellowship at Brown University. Dr. Jones currently works in Fargo, North Dakota at Stanford Hospital, where he's the director of respiratory therapy. Next, we have Dr. Kendra Shepard. Dr. Shepard is a board certified internal medicine and geriatrics physician. She did her medical training at Meharry Medical College. She completed her internal medicine residency at University of Louisville in Louisville, Kentucky. And she completed a geriatrics and health service research fellowship at University of Alabama at Birmingham. She is the center medical director at Dedicated Senior Medical Center in the Whitehaven community. Next, we have Dr. Chinelo Anamalu. She attended medical school at the University of Nigeria College of Medicine. She completed internal medicine residency at St. Joseph's Hospital at University of Chicago. She completed her Master's of Public Health at Tulane University in New Orleans and an infectious disease fellowship at University of Tennessee Health Science Center in Memphis. She currently serves as an infectious disease specialist at Methodist University Hospital, and she also holds an assistant professorship with the University of Tennessee Health Science Center College of Medicine. Dr. Danielle Tate completed her undergraduate degree at Louisiana State University. She attended Howard University College of Medicine for her medical school training, and then completed her residency at University of Tennessee Health Science Center in obstetrics and gynecology, where she was the chief resident in her final year. She decided to remain in Memphis and completed a fellowship in maternal fetal medicine, also at University of Tennessee Health Science Center. She subsequently completed a clinical fellowship in HIV medicine at University of Tennessee Health Science Center. She is currently an associate professor at University of Tennessee Health Science Center in the Department of Obstetrics and Gynecology. She's also the program director of the OBGYN residency, director of Obstetric Infectious Disease Division, and also director of high-risk outpatient services. So as you can see, our panel is quite packed. There's a lot of knowledge on this panel tonight, and we will bring you a bit of that knowledge, and hopefully you'll be able to share with friends, colleagues, and loved ones. So we will get started this evening with Dr. Keto Lord. He will give us an overview of COVID-19 in the emergency department. Dr. Lord?
Yeah, thank you so much for having me here. I think this is so necessary. 2020 has been a year, we're fighting two viruses. We're fighting this epidemic of, pandemic of COVID-19, and we're also fighting issues with facts, right? And so one of the biggest issues we've been fighting about is misinformation. It's spreading rampantly through Facebook and Instagram and other venues. So this is extremely important to talk. I look forward to answering these questions. The emergency department has been inundated with patients. I think Shelby County has had the highest level of boarding and overcrowded that we've ever had before. When you look at Shelby County, you're talking about 75,000 new patients that otherwise wouldn't be sick who were infected with COVID-19. That places an immense burden of patient care on the entire system. We've seen record overcrowding in the ED, but on top of that, we also were inundated with a lot of gun violence during the summer. So during the summer, we did see a decrease in the amount of patients that were coming through the system. Our positivity rate during the summer was about 6% in the entire Shelby County area. However, over the last several weeks, that has increased to 17.5%. So we're seeing an increase. We're going up in terms of number of cases going forward. So that means we expect to see more patients sick with COVID-19 over the next several weeks. So I think it's really important that we talk about the vaccine. We discuss kind of the risk and benefits of that, and we kind of dispel myths going forward. So I think this panel is really important in terms of helping to fix these issues. So.
Thank you, Dr. Lord. So next we will have Dr. Jones, and he will give us an overview of COVID-19 in the ICU.
Mute.
Thank you for allowing me to take part in this panel. I have a kind of different perspective, and you know, I don't see the people coming in on the front line as you do in the emergency department, but often I see them when they are kind of at the point of no return. And I think currently in the country, you're talking about 60 to 70% mortality for patients who require intubation for COVID. And the numbers are still increasing, unfortunately. And the hope is that now that people are getting vaccinated, that number will start to decline, or we just start to see fewer cases overall. But therein lies another issue, and that's getting people vaccinated. You know, I think there's, and not without due, but there is some degree of mistrust, at least in the African American community, when it comes to mass scale vaccinations. And I think that has historical relevance. And but this is something different. You know, this is truly a novel virus. You know, we've not had a chance to see this play out over a long period of time. But in the short period, we know that this is a deadly disease, and it's still killing us more than it kills other subpopulations, members of the population. So I often have conversations, at least with a lot of my fraternity brothers, about, you know, the necessity of getting this vaccine, because a lot of people are very skeptical. And again, that's, you know, understandable given our history here. But I think that this is different, and I certainly am always encouraging people to ultimately to get the vaccine, but then, you know, question why you think that it's not a good idea. And granted, there's still a lot we don't know how this vaccine is going to play out over the next year or so. But I think we know the truth of what happens when you get the disease and where that can land. Even if you're otherwise healthy, you know, you can have, you know, a lifelong bevy of issues following, you know, contracting this disease. So, you know, ultimately, I don't have much to say really from a critical care standpoint, because by the time people get to me, it's too late. Unfortunately, a lot of the times it's too late. So, you know, I certainly would speak more to the need to get vaccinated, honestly.
Thank you, Dr. Jones. So next we will have remarks from Dr. Kendra Shepard, and she will talk about COVID in primary care settings and in the elderly population. Dr. Shepard.
Good evening, everyone. It's such a pleasure to be with you. I would be remiss, everyone was telling their undergraduates, so I'm a proud graduate of Howard University, so undergrad, and then I went on to Meharry, so I just had to give that shout out. And I'm here as a geriatrician and primary care physician. You know, one of the early first outbreaks that occurred in the country in Washington was in a nursing home in a long-term setting. And at the time of the COVID outbreak, I was medical director in a long-term care facility. The older adult population has been hit very hard. Just, you know, advanced age alone is a risk factor, and then they usually would have one chronic comorbidity. So I agree with Dr. Jones. We're trying to keep them from getting it at all. As we know, if they get admitted, it's particularly if they have to go to the ICU, that they may not make it. We know that the average death rate, all cause early on, this was mid-summer data, was 25 to 30%. COVID-19 has also had some unintended consequences for our older adults and our seniors. And a lot of that is a result of social isolation. So many older adults did heed the call, and they did isolate. In settings, we've seen a lot of malnutrition and weight loss. We have seen a lot of increased depression symptoms and anxiety and early death, both just from COVID and non-COVID. What we try to do as a response, especially in my company, it's new to Memphis. Dedicated has been here since March, since September 28th was when our first facility opened, but enterprise-wide, the company made rapid switch to telehealth, both phone and televideo, because our older adults need help with the video portion. So we were able to do that. We were able to increase what we call our love calls when we reach out and make sure they're healthy, happy, and at home. We sent them masks to wear. We encourage social distancing. We do and continue to do COVID testing on site. And then if we get older adults that test positive for COVID and they have mild to moderate symptoms, we give them a COVID kit, which includes a temperature, a thermometer and a pulse oximeter. And we ask them to take their temperature daily and monitor their pulse oximetry. And we kind of treat them symptomatically. And we've been able to keep a lot of people at home doing that regimen. And for those whose O2 stats did drop, then we would send them to the emergency room. So I think also, contrary to popular demand, contrary to popular belief, older adults really do want to be vaccinated. We have sort of like unofficial polls, up to 70% want to get the vaccine. We have been educating early and often with the vaccine, even before it came out, along with our flu vaccine campaign, because in older adults, flu still kills 70% of older adults that make it to the hospital. And so we explain those things to them. And so we have a lot of literature talking about the myths and the facts, what we'll be talking about tonight. Thank you.
Thank you, Dr. Shepard. So we will transition to Dr. Anamalu. She will talk about COVID-19 treatment considerations and the importance of the vaccine.
All right. Thank you for having me. So we've come a long way from when this all started out around February, March time. And that was during the first surge. We didn't have a lot of therapeutic options at that time. And so it was just patients coming in the outpatient setting. We just monitored them. We had nothing to offer at that time. And if they desaturated or became worse, we'll send them off to the emergency room. And there was so much crowding. So fast forward to where we are right now, we've made so much progress. Now, 2 monoclonal antibodies have been given the EUA, that's emergency use authorization, by the FDA. And at this time, we offer those to our COVID positive patients who come to the outpatient setting, who are maybe mild to moderate symptoms, but they are not hypoxic or have very severe symptoms, and they have coexisting or pre-existing conditions that put them at high risk. So just a general example would be a patient who tested positive, still having fevers, and maybe some mild cough, sore throat, and has underlying COPD, diabetes mellitus, hypertension. That would be a typical patient that we would arrange for him or her to get the monoclonal antibodies. The common one we have available to us is the Regeneron. So for instance, I work at Methodist University Hospital, and we have an outpatient infusion area that was taken away from our usual infusion centers where we give, IV antibiotics as well as other medications, and we're able to send our patients there to get this therapy. Now, those that don't do very well, or when they come in, they're really sick, then we have to refer them to the hospital. And hopefully we're able to do some remdesivir, and hope remdesivir doesn't have any survival benefit, but it does shorten their hospitalization. And then those that progress that are really bad move on to the emergency room where steroids are used and all that, and mortality is very high. So what we try to do now is when we get calls or we see patients come in with COVID, we try to assess and see where they are in terms of symptoms. Is it mild to moderate? Is it severe? Bear in mind that when this all started out, there were situations or cases where you see a patient, they were doing very well, vital signs were very stable, and in 24, 48 hours, they decompensate and end up in the emergency room, and a lot of them died. So I'm very, very excited that we at this time have the opportunity to offer people some treatment in the outpatient setting and hopefully try to keep them out of the hospital. When I see patients, both inpatient and outpatient, when I see those that do not have COVID, they're in the hospital for other conditions, everybody's very apprehensive, and they will always ask you, should I get the vaccine when it gets to my turn? And so part of what we're trying to do is to encourage people to, yes, please get the vaccine when it's your turn to do that. There's a lot of apprehension. And I was one of those that was skeptical until the study came out in the New England Journal of Medicine. And it was a very robust study. And now I am an advocate, and I use this opportunity I have to speak to patients, 20, 30 patients a day, and encourage them to get the vaccine whenever it's your turn. So I'm excited for what the future holds.
Thank you. And so next we will have Dr. Danielle Tate, and she will talk about COVID in pregnancy, the long-term effects of COVID on women of childbearing age, and vaccine safety in women of childbearing age. Dr. Tate.
Thank you. Good evening. Thank you for having me. As with anything, women of childbearing age, pregnant women, lactating women are not at all immune from this disease, are very susceptible as well. And actually, pregnancy falls into the high-risk category. So it is definitely relevant to those who practice in my world. As far as patients go, when we look at numbers, because we're always asked about this, the latest and most robust studies that we have through the CDC says that about 25% or 1 in 4 women pregnant women will have or have had COVID. The majority of patients that we see, honestly, are asymptomatic. And it's not necessarily that they are truly asymptomatic. Most times they are leaning towards thinking that the symptoms they're having are just related to pregnancy, the shortness of breath that comes with advancing gestation, or writing off those symptoms as being part of something of a mild disease. Unfortunately, the studies that were done with the vaccines did not include pregnant women. So most of what we'll find out will likely be retrospective data. But with that being said, all of the governing bodies, CDC included, ACOG, our big governing body, all recommend that vaccinations not be withheld from someone who's pregnant, lactating, or contemplating pregnancy. As far as we can tell, the safety profile is there for pregnancy and it should not be withheld. However, patients, as you can imagine, will want to have discussions and may have questions. We do not also recommend that it be withheld until they speak with their OBGYN or their OB provider. It should be proceeded forward and given to them as well. Again, they're in the high risk category, so they would be ones who should be offered up hopefully here in the maybe 3rd or 4th round as those who get it if they're not already in a high risk category, meaning that they're a healthcare professional usually, or in an age group, or have a comorbidity that makes them high risk as well. With the lack of data that we have as far as pregnancy and long-term effects, we really don't have much to add as far as if it could potentially affect future fertility. What we do know is, given the type of vaccine that it is, the mRNA vaccine, it is not one that should affect the baby or the patient genetically in any way, any alterations that could lead to a genetic anomaly or a congenital birth defect, anything like that. And so patients can be reassured that that is not the case. As far as questions that I usually get asked, what I usually stress to patients the most is to know about the hospital and the pregnancy experience. And along with them being at high risk for that, there is a high risk for depression and anxiety, and a lot of things around loss of the birthing experience that they expect. You know, a lot of offices are now not allowing visitors, so partners are going the entire pregnancy without seeing an ultrasound or talking to a doctor. Many of the hospitals, because we do have to be very aware of the intimate nature of our care when we're delivering babies, are very restrictive as far as visitors, especially for a COVID positive mother. That would mean that she's not allowed to have a visitor during her delivery, as well as sometimes the baby may be separated. I do believe my pediatrician and neonatology colleagues within their realm have caught up to now allowing rooming in. But when this first started, we were isolating the babies from everyone, including mom, and not even allowing baby to go home with mom. Now, if the patient is COVID positive and very ill, she does have to know as well that the baby could be separated and have to go home with a negative family member. As far as illness, just like with the flu, they are not necessarily more likely to acquire the virus, but could very well become very sick. And we have had many instances where we had to deliver early just because of respiratory status. When we look back at complications, I do get this question a lot about potential COVID-related complications. The virus itself has not been linked to any pregnancy complications. However, we do see higher rates of preterm delivery, likely due to the status of the patient and needing to deliver to help with respiratory status especially. And there's been some anecdotal links to increased risk of hypertension of pregnancy or preeclampsia and fetal demise, but those lean more towards patients avoiding prenatal care because of the fear of contracting the virus while in the hospital or the doctor's office more than it is the virus itself. So we have definitely become very creative in the OB world with telehealth and just how we see patients just to keep them in care so that they don't run into other pregnancy complications due to insufficient prenatal care. When it comes to the medications that are used to treat COVID, this is the other question I get, is it safe? A lot of providers call me about this, and it is. Overall, remdesivir, dexamethasone is actually a medication we use for fetal development when we're doing early delivery, so that is very much so one that we recommend if it is indicated by our ICU and our ED colleagues and our primary care colleagues. One thing to note for my colleagues on the call is that we tend to use much higher doses of dexamethasone. So if you were to call the OB doctor and say, is this okay, we're going to ask you to give the higher dose in case we have to proceed with the preterm delivery. But overall, nothing should be withheld as far as the treatment regimen for the patient because she's pregnant. In addition, we do really focus on stricter supplemental oxygen requirements. I know I see sometimes we're leaning towards, okay, the low 90s are fine, but when she's oxygenating for mom and baby, you have to keep her on the higher side as well. Otherwise, I know there's still a lot of not known. I know whenever I do think we're gonna have into this pandemic, we'll have a lot of robust data come out as we gather our information from all of the labor and delivery wards, because that's where usually our patients are housed. It's a rare thing that they're in the ICU or in the medicine units.
Thank you, Dr. Tate. And so as you can see, there's a lot of information that we know about COVID. We are going to make a transition into the question and answer session. We have several questions that have come in through the Zoom chat, and also that we had emailed in prior to this event. So I will start with the first question, and this is a question for the panelists. Have you received the COVID vaccine? And I will answer personally. My answer is yes. I believe that everyone on the panel has received the COVID vaccine. Can you guys just chime in? I'm going to transition over to the gallery view so that you guys can see everyone, hopefully.
Yes, I have. I just received my second dose about 2 days ago. So yes, and apart from some pain in the injection site, I didn't have any major issues, no fevers, no malaise. The first shot was okay. I didn't have any problems. So I just got my second one and I'm done with it. Yeah, I got it.
Yeah, I got my second dose last week. I think I looked at it slightly different. I looked at it more as being a privilege to be part of the first wave of people to get the vaccine. When I think about all the patients I've seen that have been very sick, obviously with trouble breathing, having to be intubated on BiPAP, when I think about the, people in the ICU, the people who have passed, they'd have done anything for that vaccine, right? And so here we are having a debate about whether or not to take the vaccine when there's, millions of people across the world who passed away from COVID-19 who would have jumped at the chance to get the vaccine. The second thing is that I think, when you're doing your analysis of risk and benefit, one of the things we have to understand too is that if you're younger and you're looking at the mortality rate, I don't think that explains everything. The issue with this is that this could last for 2 to 6 weeks, which means that you're out of work, right? You can infect your family members, which is also concerning. And then there are chronic things like there are people who have sequelae of scarred lung. There are blood clots that put you at higher risk for blood clots. Some people have cardiac issues going forward. Strokes, for instance, are associated with this, chronic headaches and fatigue. And so it's not so much the mortality with our younger generation, but more so all of the things, the constellation of things that can happen. So if you have the risk of the vaccine, where the studies, I've looked at all the studies with respect to Moderna as well as the Pfizer studies, and you're weighing that with the risk and sequelae of COVID-19. COVID-19 is so much more dangerous, exponentially more dangerous. And so when I weighed the risk and benefits, it was really easy for me to get that second and first shot. So that's it in a nutshell.
It's a yes for me as well. I felt that it personally and professionally wasn't the most responsible thing to do not to get it, just given that I could be the one to spread the infection to many people, both at work and at home. And if I had that opportunity to just do my part in protecting, then it just made sense. And I mean, we're all very well versed with the flu shot. And I tell myself, well, the flu shot started somewhere and it had to evolve to this point, and we're just seeing that happen again with the COVID vaccine.
I just got vaccinated with my first dose on Monday as an outpatient physician. We had to wait a little bit, but we are so excited. Many people in our office are going. We say we are first in line. That is our motto. And I, again, did it for my patients and my family, being around older adults. They like to come into the office, and we're trying to keep it sanitized and safe so they can come in. We're teaching them how to do the televideo, but it would be remiss. I wouldn't be the one. I don't want to be the one that spread this disease to an older adult and everyone that, I don't want to be the one that just having that stress and that pressure off. And I have had loved ones die from, not so much from COVID, some non-COVID things. I've had family members have COVID. I've had colleagues that, again, have had COVID and have not been back to work. And you mentioned 4 to 6 weeks. It's been 20 weeks and counting. And there's just so many side effects and so many things that we don't know about the actual disease, but we have hundreds of years of vaccine research and tens of years of this current type of vaccine that we have. And so I'm going to say, I believe this is Dr. Rayford talked about what is our responsibility in addressing vaccine hesitancy. And I felt that the first step was to get the vaccine ourselves. And then the second step is to continue to educate what it is, what it's not, what it does, what it doesn't do. And that's why I'm here today.
So I'd also like to say that, I got it, and I got it for very selfish reasons, because I don't want my wife to have me sleeping in the garage for the next several weeks. As it is, I have to travel a lot. And so, every week or 2 weeks, I'm on a plane going from one state to another. And so obviously, all of our jobs entail coming into contact with patients, and particularly patients who are infected. And so, we have to protect ourselves with PPE. But I think that vaccination is critical now, that especially, again, we kind of talked about it before. There's a lot of skepticism about the vaccine, and I too was skeptical early on just because of the history of us getting vaccines in this country. That never leaves me. But I think that this is a different situation. And again, we do, as several of you have pointed out before, we know what the consequence can be. And, there really is no reason not to get it at this point. There's too much at stake. If you have, even just for yourself, but if you have a family, there's too much at stake not to get it.
I agree. And I received the second dose of the COVID vaccine last week. I had minimal side effects. I did kind of chronicle them on my Facebook page. I had some mild body aches after the second shot, but I took some ibuprofen and some Tylenol and I was fine. I feel completely back to normal today. And so we'll make a transition. Some of the questions we answered during our original talk, so I'll skip those. The next question I'll ask is, who should receive the vaccine?
So everyone, so everyone should receive the vaccine. We know that right now they're going through different stages. The healthcare workers, patients are more than 75 years old. And I believe in the last 2 days, they've tweaked to now involve people 65 years and above, and then more essential workers, firemen, policemen, and other people. So in a nutshell, everyone should get the vaccine. Like some of our colleagues have mentioned, there are special situations that we don't, really know about. This is an ongoing thing. So the immunocompromised patients, the pregnant ones, the kids who are less than 16 years old. But overall, I believe it's something that everyone should get. When you look at I've seen some videos of a few people that have had some bad reactions to the vaccine. And that's the kind of situation you're going to see with the flu vaccine. That's what we see with antibiotics. Everybody takes penicillin. One person has an anaphylactic reaction to penicillin. That doesn't mean we're not going to give penicillin to other people. So when you look at the mortality, when you look in the news and see thousands of people dying every day in this country and millions around the world, it's a no-brainer. You should get it. And the science behind it is very robust. And so it's part of our job to, we can, sit down and go through the studies, read everything. But what about, let's say, for instance, our colleagues who are nurses, who are respiratory therapists, who are cleaners, other family members that don't have the opportunity to read medical journals and understand the study. This is where we come in. We have to learn the voice and help to educate those people. They look up to us. At work, I see the nurses, they walk up to me, I'm an ID doctor, and they say, oh, I'm not going to get the vaccine, I'm not going to get the vaccine. And I look at my watch, I'm like, oh my God, I'm in a hurry, but I'm going to bring out 2 minutes or 3 and try to explain to them why it's important. You might be surprised, most times by the time I'm done, they go and get that vaccine. So I'm just glad we're doing all this, not just for ourselves, but also to educate the general public that don't have the opportunity to, go through all the studies and see how come we all decided we needed to get this vaccine.
Absolutely, I agree. I think that our experiences are profound. I know that I've talked to several people. Many people have reached out to me and told me that because I got the vaccine and I was doing well, that meant they were going to get the vaccine. And so that's something that we should continue to do. That is why we are here this evening, sharing this information with you all. Again, you guys can share this video even after it's done if you have family members who are concerned about receiving the vaccine. And then, so I want to go to a couple of other questions. We had one question that came through in the chat that said, if a person has COVID before, is there a level of immunity? Can someone talk about that and maybe even say when that person who had COVID should in turn get the COVID vaccine?
So the recommendation right now is for someone that previously had COVID to wait for about 90 days before getting the vaccine. And the reason for that is we expect some level of immunity from, when someone is done, had just suffered from the COVID vaccine. And that immunity is expected to begin to dwindle around the 3-month period. So if we have someone that recently had COVID, the recommendation is to wait for about 3 months and then they can now get the vaccine. Now, if it's someone, for instance, that was exposed to, maybe lives in a household with someone that tested positive, we still recommend that they quarantine themselves and watch themselves for anywhere between 7 to 14 days. 10 days actually if they have absolutely no symptoms, and then 7 days from the time of exposure with no symptoms, and then they can go ahead and get the vaccine. So yes, to the question, if you've had COVID before, you can still get the vaccine, but give about 3 months before doing that.
Yeah, and I can comment on that as well. I think we some of the people at our hospital have definitely who have had COVID, got the vaccine as well. So in terms of COVID-19, there's varying degrees of disease, right? We have people in the ICU and we have people who are completely asymptomatic. And what's not clear is do you have the same amount of immunity on both ends of the spectrum? And so that's not clear at this current time. So yes, in the first 90 days, it's unlikely that you get a secondary infection of COVID-19 in the first 90 days. It's not impossible, but it is unlikely. But I do know one of my colleagues who had a really tough time with COVID-19, and she jumped at the chance to get the vaccine because she didn't want to go back through what she went through before. So again, there's 90 days is if you had the vaccine, or if you had the vaccine recently. I'm sorry, if you had COVID-19 previously and you want to get vaccinated, that is possible for you.
We also had another question in the chat that said, if a person was diagnosed with COVID and received monoclonal antibody therapy, how long should they wait before receiving the vaccine?
So for our patients that we give monoclonal antibodies, we usually ask them to wait at least 2 weeks to avoid any kind of interaction between the vaccine and the monoclonal antibodies. So minimum of 2 weeks, and then we send them off to go get the vaccine.
Okay, another question we received, should children receive the vaccine, and if so, at what age?
So right now, we have 2 vaccines available, the Pfizer and the Moderna. The Pfizer vaccine is available to children from 16 years and then into adulthood. And then the Moderna is from 18 years into adulthood. There's the Pfizer study is currently ongoing, looking at children between the ages of 12 and 15 years getting the vaccine, but that has not been approved yet. So it's 16 years for Pfizer and 18 years for Moderna vaccine.
Okay. We have another question here about vaccinations between 12 and 36 weeks. Should this be occurring to reassure patients, these are 12 to 36 weeks pregnancy, to reassure the patients concerned about the risk in the early neonatal development period? I guess that's a question specifically for Dr. Tate.
Sure. There's no gestational age restriction to getting the vaccine. Because it's an mRNA vaccination, it's not going to incorporate into DNA in any way and cause any sort of anomaly, birth defect, genetic anomaly. So patients should not hesitate to get it at any point in time, whether they're contemplating, they're trying, they are pregnant, or they've just delivered.
Should cancer patients who are not taking immunosuppressants take the vaccine?
So when you look at their study, the Pfizer study, there was no specification about immunocompromised patients and non-immunocompromised patients. Actually, some of immunocompromised patients were actually part of the study. For instance, HIV positive patients who were well controlled were actually part of that study. So this is something that I feel like you have to discuss with your doctor in terms of individualized treatment, not like there's no generalized recommendation at this time that every cancer patient who is immunocompromised should or should not get the vaccine. It's something that has to be discussed with your doctor. But if possible, like my colleagues have mentioned, when you look at the risk involved in getting COVID, if you're immunocompromised and the risk of getting the vaccine, the chances are it's much better to get the vaccine. So, but right now there's no specific recommendations in terms of immunocompromised patients or how immunocompromised you were.
Yeah. And just to piggyback off of that too, if for patients with transplants as well, they should touch base with their transplant team, and they can make that decision in terms of what those next steps will be. The people who are most at risk of these are going to be people who have diabetes, who cardiovascular disease. People with comorbidities are the people who have the highest mortality rates. And so those are the individuals who are greatest at risk for issues with respect to not getting vaccinated.
And I would like to add something, just because Dr. Lord had mentioned transplant, because it's very important to note that the COVID vaccine, the corona vaccine, is not a live vaccine. Okay, so this is something that we, typically avoid in immunocompromised patients, like live vaccine. So this is not a live vaccine. So I want to make that very clear.
Thank you for bringing that up as well, because we typically avoid live vaccines in pregnancy, and that's not the case as well. So making it safe.
Okay. One additional question that came in, is there any guidance on the development of autism in a child born to a COVID vaccinated mother?
We do not have any evidence on that yet. That will probably be in the years to come as we analyze data. And I would say anything that comes out, be very thorough in your analysis of it, because a lot of the data we get just in general on things like autism, very skewed or very muddied with other conditions, and not necessarily the one thing they're trying to link to the condition itself.
I agree. One thing that I will add, I will put on my pediatrics hat at this time, the things that have been postulated to cause autism, the thimerosal and all of those things that are in other vaccines, those substances are not in this COVID vaccine. So and generally, there should be no risk for autism in a child that's born to a COVID vaccinated mother. I think there's another question here that talks about Moderna states that their vaccine is expected to last 1 year. Native immunity is expected to last 90 days. Can anyone talk a bit about that?
So remember that this vaccine thing is still very new. So there's a lot we don't know in terms of how long. The 90 days for native immunity is what there are studies, ongoing studies right now to actually see how long people that have had COVID, the antibody lasts in the system. So we don't know. So that 90 days is not like, at 90 days, you don't have any more immunities or you have less immunities. It depends on what your titer was when you started in the first place. So right now it's difficult to tell. There's still so much unknown at this time. And even as they give me these vaccines, because there's some argument going on, I'm sure you guys are all aware about whether people should just receive one dose, because the study showed that about 50, actually to be exact, 52%, you get the immunity about 52% with the first dose, and then it goes up to 95% with the second dose. And now that there are concerns about getting everybody to have enough doses to go around to the entire population. Some people are recommending maybe just do 1 dose. And the argument there is that the study was done with 2 doses to get the antibody to the maximum you can get it. So there's still a lot unknown at this time. And, we're all hoping for the best, at least maybe 1 year. And by then, hopefully some more studies can come out to guide us.
Okay. Another question that we have is for the person who's had COVID or who has COVID currently, what can they do to prevent progression of their disease? Are there any home remedies or formulas? Dr. Shepard, since you're in the outpatient setting, do you want to shed light on any home remedies?
Yes, we don't advocate for any home remedies, but people ask, is it okay to take zinc and vitamin D and vitamin C? And we tell them it's okay to take those. There is a high level of people using vitamin D in the community. We do encourage that. We don't we don't have any studies showing that. So, but we do think if they want to build their immune system, we do tell older adults that it's safe to take zinc, vitamin C, and vitamin D. Those 3 in particular. In terms of if they have COVID, we've been treating their symptoms. So if they have a terrible cough, it's keeping them up at night, then we send them prescriptions. We drop off stuff for them. And we keep a close eye on that O2 sat. And if we feel we can manage them safely, we do. And if not, then we send them to the hospital.
And Dr. Shepard, I think you answered this question in the chat, but can you just speak publicly about the kits for seniors and really how that can be utilized for many people?
Absolutely. So we encourage every practice. So this is something that we developed at Dedicated, where if our patients come, we have the PCR and it comes back in a day or 2. It's not a same day. We don't have a rapid formulation. And so if it comes back positive, then we have purchased thermometers, a pulse oximeter, and hand sanitizer. We put that in a kit. We call them every day and ask them what their temperature is, what their O2 sat is, and have them call us at any time, day or night. We have an on-call physician, and they also have our cell phone number, so they can call us directly, and we can guide them. And we've had good result. I believe unofficial data, there was 25% of people never even had to go to the hospital by doing just really good primary care, intensive primary care.
Thank you for that. I know that I've had many people ask me about what they can do at home, and that is my recommendations as well. So it can certainly be utilized all over. And let's see here. The next question I have, is it true that there's no consequence to taking the vaccine earlier than 90 days following a COVID illness? In this case, a high-risk person may want the additional protection of a vaccine as soon as 2 weeks, similar to the monoclonal antibody treated individual. What would your response be to that?
Yeah, so the recommendation is 90 days, but we've seen people actually, I actually have a partner who went through this, and less than 3 weeks later, I was like, I'm getting my vaccine, so it does make sense. So it's just a recommendation, or rather like a guideline. So maybe somebody that's very high risk might, feel the need to get it a little bit sooner. Then I guess they might be able to do that, and somebody else might want to get it a little bit later. So there's no hard and fast rule that it has to be 90 days on the dot. So I've seen people, colleagues of ours, that have gotten the vaccine less than 90 days and they're still doing okay.
Can you speak a little bit on the amount of side effects from the vaccine in a person who maybe had COVID-19 disease and then they're getting the vaccine?
So the side effects would be basically what you would get with any other vaccine, not necessarily in relation to the COVID-19 symptoms. So the main problem, or rather the main side effect, was pain at the injection site and some swelling and maybe some redness and then some fatigue, and you will get that with other vaccines as well. I usually get those symptoms with my flu shot every year. So there's no particular symptoms that you would find in someone that's just had COVID-19 that got the vaccine that would be different from somebody else that did not get it. So it would be the general symptoms of a vaccination regardless.
I think related to all of that, I did get a question. I'm going to pass it to the panel about, we're not doing a really good job, I think, of measuring asymptomatic spread. So if a person does have COVID but don't know they have COVID and they get the vaccine, do you think symptoms will occur, or they'll just keep on rolling because they already have maybe producing antibodies or whatnot?
All right, so this is actually a very common question that we're seeing now in our ID forums. They've been healthcare workers who got the vaccine, and then a day later, 2 days, 3 days later, they tested positive for COVID-19, and then the question comes up, did they get the COVID? Like I was trying to explain to one of our nurses, they said, I got the COVID because I got the vaccine. And I was like, absolutely not. This is not a live vaccine. So no, I think Dr. Lord might be able to help us out a little bit here and explain it some more.
So there was a question, say the question again. It was more so about the vaccine and the symptoms associated with that.
So say you don't know you have COVID, but you do, and you get the vaccine. So I had a question. They were like, should you get tested for COVID before you get the vaccine? Because there's so much asymptomatic spread. That's the actual question.
And again, I think part of it is unclear in terms of all infections the same, right? So if you're asymptomatic, producing the same type of immune response as your very sick ICU patient. And the answer is we just don't know. What we do know is the vaccine has been shown to be safe in patients who've had had COVID-19 before and patients who have not. And so, my recommendations would be, obviously to try to get the vaccine and definitely make that the next step in terms of your treatment plan. So I wouldn't hesitate not to get the vaccine if I had a previous infection.
So we hear a lot on social media about the side effects that are associated with COVID. I think we touched on it briefly, notably the Bell's palsy. Can someone make comments about Bell's palsy and how frequent it was or not with receiving the COVID vaccine?
So there have been just a few isolated cases of people who received the vaccine and developed Bell's palsy. I know there was a nurse out in Nashville that had developed Bell's palsy. And it's important to point out that, things like, people are worried about things like transverse myelitis that was seen during the trials of the AstraZeneca vaccine. These are also some of the things that you can have with other vaccines. There have been patients that received a flu vaccine and ended up with Bell's palsy too. It's hard to tell, so when you look at the advantages of getting the vaccine and then the chances, of having one of these isolated cases, it's almost impossible to predict who is going to have Bell's palsy and who's not going to have, who's going to have transverse myelitis or who's not going to have. So it's almost impossible to predict that. So the cases that have been reported to the FDA have been very, very few isolated cases. So they're still collecting data to look and see, but there hasn't been anything major to halt vaccination process or anything like that. And so it's just impossible to tell who is at risk of getting Bell's palsy or not.
Yeah, and I could comment on that too. I think part of it is when you're testing, thousands and thousands of people, some will get sick with other conditions too. And I think the challenge is trying to separate what's related to the virus, to the vaccine, and what's not related to the vaccine. And this basically, I believe that people in both groups, even the placebo as well as the treatment both arms, there is people with Bell's palsy in both of those groups. Same thing with a lot of the side effects. It's very difficult to discern whether or not it's related to the vaccine or just the population. And so I think that's one of the challenges with the CDC. But they do investigate all of these side effects very seriously. They take them extremely seriously, and they do report on them and they do track them. But as of right now, there is no definitive link toward the COVID-19 vaccine and Bell's palsy. They had not made that link.
I think also it's important to highlight that although Bell's palsy is inconvenient, it is not going to cause you death. And so that's something that we should certainly highlight here. COVID disease is major and Bell's palsy is relatively minor. And so with that being said, have there been any associated deaths with the COVID vaccine?
Not to my knowledge. If you look at the clinical trial, the Pfizer clinical trial, there were some deaths, both in the placebo group and those that received the vaccine, but they were actually from other causes. As in somebody was a cancer patient and later died, the other person with an MI and stuff. So, but there hasn't really been, at least for the Moderna and the Pfizer vaccine. I know there was one that was reported in Europe with the AstraZeneca that they had halted the trial and then started again. But to my knowledge, based upon what we have available to us right now, the Pfizer and the Moderna, no, I mean, people you're gonna have, if you're looking at the all-cause mortality, 28-day mortality, you have to, embrace all that thing. So like I say, there were some deaths in the two arms of the studies, but they were not related to the vaccine.
Yeah, exactly. And I agree 100%. There has not been a link toward mortality or death with respect to the vaccine, just to make it clear. All deaths are absolutely investigated and looked at and looking to see if there's a link between the two, but there is not a link at this current time of the COVID-19 vaccine and mortality or deaths at this current time. And just to piggyback on that, I think that the estimates are like 8,000 people die per day, right? And so when you think about 28 days or a month, you're going to have a lot of people who just naturally die. And again, it's very difficult to determine which is which, whether or not it was due to natural causes versus something else. And so we haven't seen a trend or uptake to suggest that definitively that this is a dangerous vaccine or anything like that.
So there was a report. There was a physician in Florida who developed ITP after taking one of the vaccines. Can you guys just comment on this and whether the vaccine itself was the cause for that person to die, or if it was possibly something else?
I think it's one of those things where, it's being investigated now, and I know exactly what you're talking about with the ITP case. It's being investigated. As of right now, there's no definitive link between, the ITP in this patient's death and the vaccine. I think it's something that we need to look at. And I think this is what we're saying, is that we need to continue to look at these things in terms of studying them. But as of right now, this particular case that happened, I believe, 2 weeks after the patient was vaccinated, they haven't made a definitive link with that. And I do want to just kind of put the focus back on the mortality of COVID-19. I just want to, it's interesting. I think part of the problem there that this debate is sometimes we don't talk about risk and how do we make good assessments of risk. And I think this isolated ITP case versus the millions of people across the world who have died from COVID-19, it's very obvious that COVID-19 was largely associated with a lot of mortality and morbidity. And so the risk of you getting a stroke, the risk of you getting a blood clot, the risk of you having fibrotic lungs, the risk of you missing work, the risk of all these different things, severe disease, high hospital bills, all are part of that COVID spectrum. And so that far outweighs the risk of anything we've seen with the COVID-19 vaccine.
Absolutely. So a couple more questions. So what is your estimate of when things will be able to go back to normal based on the current vaccine rollout? I think everyone should answer that question.
I'll start, since it probably is the easiest one to say, that I don't ever think we'll get back to normal as we knew it before. We, especially in the OB world, are figuring out a new version of normal. I do honestly believe that limitations in visitors and wearing masks, that's going to be our new normal for a long time. Because even though vaccinations will eventually be available to everyone, it's not mandatory. So we'll still have to take those precautions until we see a turn. Maybe 2022 will be our year.
I agree with you. Yes, so because the main emphasis during vaccination process was to get a herd immunity, and looking at where we are right now in terms of rollout and all that, I don't see that happening maybe till later part of this year. So I think everyone we should just get used to the new normal to some extent, and and see how it goes maybe by next year. So it's weird. I don't know if you guys have experienced this. Even if you have your mask and you're in the grocery store and someone is close to you, you involuntarily walk away, or like, oh my God, get away from me. So, yeah, so maybe by next year, hopefully we can get the entire population or most of the population vaccinated by later part of this year. And again, just like you mentioned, this is not something that's mandatory. So you're still going to have people that will refuse to get the vaccine regardless. Remember that even in the hospital setting, we still have our colleagues that do not get the flu vaccine. And so I don't know how long it's going to take to achieve that herd immunity.
Okay, I'm going to be the optimistic one. I know we are behind, and the reason it took till Monday for me to get my first dose is because I believe the week prior, like only 1% of eligible people had been vaccinated in Shelby County, and I'm like, what's going on? What's happening? And so we just need a better coordinated effort. Now, we've already started priming. Listen, wear your mask, social distance, use your hand sanitizer, stay healthy, happy at home. However, I put out a call to all the tech people, we need more PPE so I can start reusing the kind that I have. Can we get some rapid test that is approved? I'm still waiting on that. I'm still, there are other ways to open vaccine is like that key, but we have all of these other tools that we need to develop. I'm waiting on the pharmaceutical industry to continue to have more effective treatment. So the reason I want the people, the lay people out there, like, why, I know you're tired and you don't want to stay at home. And like I just said, for my older adults, this social isolation, it's wreaking havoc. Dr. Tate talked about the mamas being away from their babies. I know, that's been revised, but just think about that for the older adult being alone. And so there has to be a way to congregate safely. And I think we have a lot of pushback and angst And therefore our cases keep going up and up. You know, they keep saying this is the deadliest day so far. I'm so tired of hearing about the deadliest day so far. But you know, if we can get some coordinated effort, and like we said, whether it's person to person, and also just making an impact, keep having these forums so that, you know, we can get 70 or 80% of the population. It's a large task, but we can do it. But I want all that other stuff too. I want all the other stuff that we can put in our toolbox to fight this disease.
Yeah. I think I'm a little less optimistic, unfortunately. I think with the rollout of the vaccine, the number of people who are getting it, some of the pushback even today about wearing masks, we have an uphill battle, guys. I mean, we have a really big uphill battle. I don't see 2021 as reaching back to normal. And I think you're saying a new normal. I think in our ED, we've actually changed the way, this is the new normal. This is how we are, mask all the time, always wearing our PPE and all those different things. I think what we'll see kind of a similar phase to last year. What we'll see is probably a decline in the summer. We'll see it with the people who are getting vaccinated. I think we've vaccinated about 10 million people so far. I think 23 million have had the disease so far. So that's about 30 something million. But that's still like less than 10% of the entire population, and herd immunity anywhere, 80% or so. So we're far away from herd immunity. But my concern though is that just like the summer we saw when the positivity rate was 6%, and now we're at 17.5 as it gets colder, my concern is in the winter, we might see it uptick again. So I think, when people are considering the vaccination and trying to weigh the risk and benefits, if this is for me, I would say is that I don't see COVID-19 going away. And I think the vaccination is the only viable solution for us not to get infected going forward. So I think it's incumbent on us to really make sure that we're getting vaccinated, wearing our masks. And I think that'll help to expedite us getting closer to normal.
One other thing I want to say, Dr. Washington, before you come on, is what I reminded people is, what we call the Spanish flu. I don't know the correct term. It's the flu that we have today. It's the H1N1 strain. And so when I went back and looked, there were 5 surges or 5 strains over 2 years before they could get that, before people reached herd immunity, because there was no there were vaccines back then, but not one for that, and they did not have the tools that we have 100 years ago to come up with a vaccine. So even though, and this is what's so interesting to me, that history is repeating itself, we do have some technology, and people are tending not to trust it because of other history that we've had, so definitely we're going to preach it. Yes, it may take an entire 2 years, but we want people to understand. We forget how, now people are like, I'd rather get the flu. I don't want the vaccine. And I'm like, 22,000 people still died from the flu, and 70% of them was over 65. It's insurance. We're trying to get you. So one day I'm going to be saying that about COVID-19. I just pray it lasts longer than, I hope we don't have to get it every year. But yes, one day that will come. But like we said, it might be 2022. So, Dr. Washington.
I would like to make a very quick comment. Well, because of all the, mitigation process in place, the mask wearing, hand sanitizing and all that, we actually have a major decline in the number of flu, we're seeing these days. And, we have this system where you can test for the influenza, RSV, as well as COVID-19 all in one test. And so that has also helped in terms of the flu. So not just for the COVID.
Yeah, agreed. I think that is something that we need to highlight. So a couple other questions in the chat. We had a question asking how common it is for children, but I would throw in adults as well to continue to have a positive COVID test several weeks after infection, even when they're asymptomatic.
Yeah, so this is actually a very challenging question that is something we ask and discuss all the time. In children, there have been basically cases of prolonged shedding, where they continue to shed the virus, even though it's not a very infectious, virus, but they shed for weeks and for some people for months. And this has also been seen in very immunocompromised patients where they have prolonged shedding. So it's difficult to tell whether, and that brings up the case of, is this reinfection? Because you have patients that had COVID and then you test them 2-3 months later and they're still positive. And the question is this reinfection, or is this something that's still, lingering, viral shedding from the previous COVID? So these are all things that, we don't have the, one answer for. It's still an ongoing process and we're still trying to learn and understand.
Also, an additional question. So we've heard a lot in the media about these new variants of COVID-19 with the mutations. So 2 questions. Number one, do you feel that is going to be a major threat in this country? And then number 2, is the vaccine going to work against these variants?
Well, so we are aware of the strain from UK, the B117 strain, and then the one from South Africa. And I know the one from the UK has been spotted in several places here in the country, Colorado and California and other places. And so far, because I listened to I forgot the guy's name, on one of the Pfizer guys, and they still feel that their vaccines are still going to cover for those strains. So right now, we don't have any studies or any evidence of those strains being resistant to the vaccine. We don't know what's going to happen maybe in the next 6 months, 1 year, who knows? But for now, those strains are believed to be covered by the vaccine.
Yeah, and it looks like at least the variant in the UK, it spreads more, is more contagious, but looks to be a little less virulent in terms of some of the bad outcomes that happen. So then that's, and part of it too. The other question too is the testing, that we just don't know in terms of whether or not the tests that we have, because a lot of variation in the different types of tests that are surrounded in the United States, are they picking up these variants, or are they missing these variants and things of that nature? So I think we'll find a lot more information in the next few months regarding these new mutations, and we'll be able to tell you a little bit more information down the road.
All right. Okay, one additional question we had in the comments. Have there been any discussions about making the vaccine mandatory for school-age children or for college-age young adults to attend in-person classes and school-related activities?
Well, where we are right now, remember that only for the Pfizer vaccine, only 16 years and above can get the vaccine. And then for the Moderna is 18 years. So for now, school-age children, we don't have any vaccine available for them. And so we don't know if it's something that's going to be mandatory. For instance, there are some of the vaccinations that are mandatory, some are not. We don't know at this point. We don't even have any available for kids less than 16 years at this time. So hopefully when the study comes out and we look at all this, then we might be able to make an informed decision. But right now, we don't know.
Okay, I think we have a few. I'm sorry, Dr. Lord, go ahead.
Yeah, I just also want to just let everybody know, at this current stage, we don't have enough vaccines for everybody, right? And so I think part of it is just understand this is a limited resource. And if you're able to get it, it's a privilege, try to get it if you can. But as of right now, we don't have enough vaccines for everybody in the United States. And so that's the reason why we have the different tiers we rolled out in a systematic way in terms of 1A, when being in different people and trying to get the people who are highest risk. But as of right now, we don't, in the 2020, 2021, I don't see them making any mandatory guidelines. I can't see that.
Any comments? I've had several people ask if I had a preference of which vaccine to receive, whether Pfizer or Moderna. Can someone comment on that?
Right now, I don't think there's any preference. The Pfizer is the first because it rolled out first, and that's what many people have, and then the Moderna. In the next 2 months, the AstraZeneca, which is what is currently available in Europe, especially in the UK, that's what they're using right now. So I think it just depends on what you have available to you. There's no preference. Both of them work basically the same way. They target the same protein, the spike protein. And, in terms of efficacy, they're almost, at par. So it's no preference. I think most places around here, we all got the Pfizer because that was the first to roll out, and Moderna came like a week later. So some places are going to start off with the Moderna, depending on the state or where you are. So there's no preference. If, for instance, my facility, what we got was the Moderna, I will get the Moderna. But we got the Pfizer because that's what they had available to them.
Yeah, I agree. The advice that I've been giving everyone is get the vaccine that is available to you as soon as it is available, regardless of the brand. Okay, so a couple other questions that we have in the chat. I do want to ask this question because it is certainly an important part of the conversation. How do we as physicians address the Tuskegee study and misinformation and conspiracy theories as it relates to receiving this COVID vaccine, and even whether COVID-19 is real? Everybody can take a shot at that one.
Yeah, I mean, it's tough, and I think part of what's kind of been layered on top of this is the politicalization of COVID-19, which has made it exceptionally challenging to actually communicate the facts to patients, right? So wearing a mask does really work. I wear a mask every single day and around COVID patients all day in the emergency department. With respect to treatments that weren't actually efficacious, so it's been a lot of misinformation out there. What we need to do is, as physicians and even people who are on this, who are actually looking at this now, is to go out to our community and begin to tell people the facts. Part of the problem is that when you look on the internet, you look on YouTube, you look on Instagram, how do you distinguish between something that's real and something that's not real? And I think physicians, we have historically had the one-on-one conversations. We've had, journal studies, TV interviews. What needs to happen is we really need to be on social media. I mean, that is where people are getting a lot of their information, and we need to be there at the front and center helping to dispel a lot of these rumors and tell people that it's safe. So I would not tell you to get the vaccine if I had not gotten it myself, okay? And so just to be clear, I've received the vaccine. I reviewed the literature behind it. I fully support it. And so anybody who's hesitant about that, let me be proof that I think that it's a safe vaccine. But I think social media is really going to be the next platform. We can't even meet any longer because of COVID-19 restrictions, so it has to be the next platform. But I do think we need to really begin to push and dispel those rumors online.
Any other comments?
I agree. It is very tough in this era, especially if you are African American or a person of color, and you are dealing with mistreatment right now. So I think there's two different versions. There's a misinformation, because we live in a world of misinformation right now, where you can just see the stuff that you believe, even if it's not true. Facts have been lost. And then you have sort of this history of, and it may not even go back to Tuskegee, or it may not even go back to the Holocaust. It may be, well, when my mother was in the hospital, when my grandmother was in the hospital. So really sitting down and going through and building that trust with each and every patient. That's what I have to do. I have to sit down, and then of course, absolutely being on the front line and saying it's safe and why it's safe, and why I would not, why it is safe and why COVID is real, because we know it's real, and they know, and so we just deal with that one person at a time. We be very kind about it, be very empathetic about it, and one person at a time.
I agree with what you said. I'm from Nigeria, and it's ravaging Africa Nigeria in particular. And I talked to family members who still don't believe there's COVID, because it has basically the same presentation with malaria that is endemic, right? So now everybody that they don't bother testing for COVID. Oh, it's malaria. COVID does not exist. Oh, it's only over there. And you have to, hold your tongue from screaming and, take out the time to try to explain to people it's real. And that's the same thing we do here, not just with COVID patients, but even just our regular patients, people, your co-workers. There's still people that work in the hospital that know there's a COVID floor, that we have COVID patients and all that, but they don't believe it's real. So we have to take out that time and try to reach, even if it's just one person at a time, also reach out on social media and talk to people. Sometimes when they see people that look like them, they would listen, they would believe. I don't know how many times I've come in and patients will ask me what the other doctor has said, just to make sure they heard it from someone that looks like them. So I feel it's something that we can play a bigger part in and try to spread this message that is real and is killing people, and please get vaccinated when you can.
I definitely agree with everyone. And then too, just trying to see what's motivating them. Sometimes if you can get to the reason why they have so much distrust, that can help with dispelling whatever myths they have. We also sit in the Bible Belt, so definitely hear a lot of the religious beliefs behind what may be driving this disease, as well as the vaccine, right, that we try to negate it. But again, it's always about educating yourselves, and we stay educated so that we can educate correctly. But we deal with that in medicine, I feel like, all the time, right? They're always Googling something or talking to someone or having a story about someone that we have to negate in any part of what we do every day. And we just keep pushing forward. And you're right, using the platforms, we have to evolve just like every other part of society. Medicine can be archaic in how we get our information to our patients.
Yeah, absolutely agree. I have been asked these questions many times, and I say that, the mistrust has been earned, and the trust also has to be earned. It's not something that's just going to happen overnight. And so we really have to really reinforce the things that we're saying. Patients have to understand where we're coming from, and that may mean us not speaking in medical jargon and speaking to them so that they can understand. And unfortunately, some people aren't going to believe until it affects them or someone in their household. I don't want that to happen to my patients or to anyone in our community. And so we really continue to work on that. Again, that's why we're here tonight. That's the main reason that we are here. And we have committed to providing the community with information anytime that they would like to have information about COVID. So for those of you all who are on this panel, thank you for joining us. For those of you all who are listening in on the various platforms, thank you for joining. Please feel free to share this video. Please have them follow the Bluff City Medical Society Facebook page. We also have a YouTube, an Instagram, and a Twitter. I will share the slide here with you guys so that you can see what our social media handle is. If I can get the slide, there we go. So we're at Bluff City Med on all of those platforms, Facebook, Instagram, and Twitter. We will upload this video to our YouTube channel so that it can be seen later. And we will also link it to our website. Our website is bluffcitymedicalsociety.org. I do have one other thing to show you guys, something that I'm very proud of. Let me see if I can get it to load, that we can share with you all before we close out our evening. Let's see, I'm not a very techie person, so I'm gonna try this. And before I am not throwing away my shot. I am not throwing away my shot.
Hey, yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not throwing away my shot. I'm gonna get a scholarship to King's College. I probably shouldn't brag, but tag our names and astonish. The problem is I got a lot of brains, but no polish. I gotta holler just to be heard with every word. I drop with knowledge. I'm a diamond in the rough, a shiny piece of coal, trying to reach my goal. My power of speech, unimpeachable. Only 19, but my mind is older. These New York City streets get colder. I shoulder every burden, every disadvantage. I've learned to manage. I don't have a gun to brandish. I walk these streets famished. The plan is to fan this spark into a flame. But damn, it's getting dark, so let me spell out the name. I am the A-L-D-S-A-N-D-E-L-E-L-N-T-E. A colony that runs independently. Meanwhile, Britain keeps shitting on us endlessly. Essentially, they tax us relentlessly. And King George turns around on the spending spree. He ain't never gonna set his descendants free. So there will be a revolution in this century. And to me,
he says in parentheses,
don't be shocked when your history book mentions me. I will lay down my life if it sets us free. Eventually, you'll see my ascendancy. And I am not throwing away my shot. I am not throwing away my shot. And yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not throwing away my shot. I am not throwing away my shot. I am not throwing away my shot. And yo, I'm just like my country. I'm young, scrappy, and hungry, and I'm not throwing away my shot. It's time to take a shot.
I dream of life without a monarchy. The unrest in France will lead to anarchy. Anarchy, how you say? Anarchy. When I fight, I make the other side panicky with my shot.
Yo, I'm a tailor's apprentice, and I got John Knuckleheads and local parentis. I'm joining the rebellion, cause I know it's my chance to socially advance. Instead, it's always the pants that don't take it. But we'll never be truly free until those in bondage have the same rights as you and me. You and I do or die. Wait till I sally in on a stallion with the first black battalion of another shot.
Geniuses, lower your voices. You keep out of trouble and you double your choices. I'm with you, but the situation is fraught. You got to be carefully taught. If you talk, you're gonna get shot.
Check what we got. Mr. Lafayette, hard rock like Lancelot. I think your pants look hot. Florins, I like you a lot. This hatch a plot blacker than the kettle calling the pot. What are the odds of God you put us all in one spot? Pop in a squad and conventional wisdom like.
So that was many Bluff City Medical Society members who are all Memphis locally Memphis, who have received the COVID vaccine. We wanted you all to be able to see that we actually are getting the vaccine ourselves and that we're all doing well. Many of them are in the comments on the various social media platforms, on this Zoom call, also on Facebook. And so we thank you. Again, if you have questions, we are happy to answer those questions. You can send a message. You can go to our website. We do have a contact tab on our website, and definitely go in and get that information. We're happy to provide anything. So we thank you for joining us this evening. We're a little bit over our time, but I think that we had a robust discussion tonight. And again, when things change, we'll come back and we'll talk to you guys some more. We really want everyone to become more comfortable with the new normal and also with receiving the COVID vaccine so that we can get back to more of the normal that we were used to before. So thank you, everyone, and have a good evening.
Thank you.